If the answer, there's a lot of things that you don't.
No crutches.
No crutches. Thank you. Hello, Dr. My name is Charu. I'm the communication specialist at Summer Session.
Oh, great.
Nice to meet you. I have met you before. I don't know if you remember.
And you look very familiar.
I was in a marketing class with Lily.
That's exactly where I thought it was. I'm like, oh, wait a second. That's exactly where I thought it was.
I'm graduating and everything, so
Oh,
we're good.
congratulations.
Yeah.
Congratulations. I know. Yes. Well, we're watching. Really?
It's likely. People have been calling us to ask how soon your presentation is going to be on the air so they can view it from their homes. So you do know that, right? No stress, no pressure.
I should be flattered.
Who should
It just
we?
makes my heart beat faster.
And actually, yesterday, one of our Gretchen Murphy, do you remember her? Yeah, she's one of our other presenters besides Robert, and she's like, yeah, she did my cataract surgery, and it was amazing. And I was like, well, we have like people in-house there, so you have great reference.
Oh, good. Thank you. Thank you very much. It's always nice here. I get to try person my parents. So. More people turned out than I
Do you know
expected.
about the little dog that's outside who's trying to come in the building? In brown and yellow. Do you want to make an announcement that somebody had actually left their dog? Now the dog is with Campus PD. Safe and very friendly. Brown and yellow, very friendly female dog.
We're just about a minute before we begin, but I've been told that there was a little brown and yellow dog that was outside,
Medium-sized.
medium-sized, and if that's your dog, he's being cared for by the campus police department right now. So he's got a little radio collar on now and handcuffs. And so get him out of jail by posting bond, I think. But anyway, just in case you need to find me.
Okay, thank you.
Well, it's almost time, so I guess let me begin. Welcome to the Healthy Living series. I'm Robert Hannon, and this is one of the wonderful events that UAF Summer Session puts on all summer long. Let me just take a moment and ask you, if you haven't already, I mean, you look like you're astute people who've been around in public before. If you have a cell phone that is loud and needs to be turned off, this is a great time to do it. And let me tell you while you're doing that there are some other events taking place. For example, tomorrow, right here, Steve Peterson, who's sort of like the beekeeping guru of the Tanana Valley, we'll talk about the Summer Sweet Rewards beekeeping. So that's something to look forward to. And Thursday, Music in the Garden will feature Ukulele Russ. Now, he's not your dad's ukulele player, but I always wanted a moniker like Ukulele Russ. You know, wouldn't that be a great name? And finally, on next Monday, before the next Healthy Living series, there's a wonderful Magical Monday event called Hidden Animals of Alaska's Seas, and Arnie Blanchard, a marine scientist, will be talking about that. So, lots of events to choose from. Let me just kind of discuss a little bit how we might proceed this evening. Dr. Johnson will obviously start talking about it. She's got 3 main sections, so what we thought might work would be at the end of each section, there'd be an opportunity to ask questions. And as we draw to the 8 o'clock hour, if there's universal clamor for more questioning, we take a little pause at about 8 o'clock to allow people who have other events they want to go to or just take a short break, that opportunity. And then if there are a number of people who still want to ask questions, we can kind of go on there. I've been told, though, this is a smart classroom. Well, actually, the whole building's pretty darn smart because at 9 o'clock, the door's locked, whether you plead with it or not. So if you're still in the building, you can get out at 9 o'clock. You just can't get back in. So don't leave anything when you exit the building. So without further ado, let me introduce tonight's speaker, Dr. Katherine Johnson. She's board certified by the American Academy of Ophthalmology. Dr. Johnson began her education graduating with honors from Harvard University. I've heard of that place. She received her medical degree from the University of California, San Diego School of Medicine. She completed her specialty training in ophthalmology at the renowned Bascom Palmer Eye Institute of Miami, Florida, an institution which continues to be ranked as the #1 eye hospital in the nation, and that's by U.S. News and World Report. Dr. Johnson spent 6 months treating patients in rural Mexico. She worked with the SAVE Foundation to perform cataract surgery in rural Nepal. And most recently, Dr. Johnson co-founded the Prevention of Global Blindness Fellowship, which sends ophthalmologists around the world to treat eye disease and train doctors in the developing world. So please give a warm welcome to Dr. Johnson.
Quite a turnout when my back was turned. Can everyone hear me? I think it'd probably be easier for me. I tend to have a very loud voice anyways. So, yes.
Dr. Johnson, for the viewers who are going to be watching the video, is it
Microphone.
possible if you could use it, please?
I think this is my first time actually using the microphone. I always get away with just yelling. Okay, my name is Katherine Johnson. My friends call me Kara. It's very nice to have you all here. I'm going to be talking today about your aging eye. Primarily about 3 separate conditions that are really common in the Asian population. The first is cataracts, second is glaucoma, and the third is macular degeneration. If I'm talking too fast, please just ask me to speak slower. I can do it despite the fact that I speak like a million miles an hour. Okay, so let's talk a little bit about the eye in general. Most of the parts of the eye that I'm going to talk about are going to be a foreign language to you. So briefly I'm going to go over, and if you can see the pointer, to give you a basic anatomy of the eye. The cornea is the clear part that you look through. So you shouldn't actually be able to see it. When you look at my eye or look at the person next to your eye, you actually will be seeing the pretty colored part, and that's called the iris. The cornea is the clear part, but that's actually a very crucial, important part of the eye, and we'll talk a little bit more about that in relation to glaucoma. And then you have the iris, which is the pretty colored part of the eye. Where the cornea and the iris meet is called the angle. We'll talk a lot about this when we talk about glaucoma. That leads right below that to this area called the ciliary body. The ciliary body is where fluid is made in the eye. We'll also talk about the lens. This is where the cataract forms. You can see these little fibers actually that connect the bag that the lens comes in. Is connected 360 degrees to the wall of the eye with these fibers called the zonules. the ciliary body has little muscles in it that pull on those zonules, and when we're young, are able to change the shape of our eyes to be able to see out at distance and up close. Unfortunately, that's one of the things that I'm sure you all have noticed, that you can't quite see up close anymore because that ability to change the shape of your eye goes away with age. My 5-year-old son can read something right there, but unfortunately I'm about there, and you guys are probably right about there. And so that's why we need reading glasses. It's because of those fibers. We'll talk a little bit more about that later if you want to. Then we go back into this big cavity in the back of the eye. The majority of the back of the eye is called the vitreous. It's actually a remnant of the scaffolding for when the arteries in the back part of the eye came and they actually formed the front part of the eye, and then those blood vessels actually regressed back because there's no blood vessels in the lens, there's no blood vessels in the cornea. There's some in the iris, but the rest of it all needed to be formed. And then those regressed back and they left that big vitreous humor. The vitreous is when people talk about the vitreous detachment, where you see the bright flashing lights, floaters, floating strings that many of you have seen and we've talked about in clinic if you've seen me for that. That's actually the jelly separating from the retina. This is something that's left over from when the eye was formed in utero. Then we go beyond that into the retina. The retina is the actual photoreceptor. That's actually where the light is. Basically, the light rays are chemically changed by the photoreceptors into a neurologic signal that then travels along the nerve fibers in the retina and goes out into the optic nerve, and the optic nerve then takes it back into the back part of the brain, and that's how sight's interpreted. So that retina is the film of your camera. If you can imagine a camera, you have the lens in the front part. No, now take an SLR camera. So you can take that lens off and put a new lens on. But the film is the film is the film. That film is the chip. And that chip is unfortunately unchangeable. It is actually, the retina is actually brain tissue. So it acts similar to other brain tissues such as with strokes and spinal cord injuries, non-regenerative unfortunately, but it scars and acts similar to brain tissue. So the retina is simply an extension of the brain, similar to the optic nerve is an extension of the brain. So to talk a little bit how the eye actually works. So essentially we can think of the eye as a camera. Light rays come in parallel from the world around us. So the light rays come in parallel. The entire purpose of the eye is to take those light rays and focus them onto a sharp point onto the retina. So there are 3 major surfaces that I talk about, and the first surface is actually the tear film. So sometimes we talk about dry eyes affecting your vision, et cetera, et cetera. That's one thing that is often overlooked is the tear film is actually the first surface that the light ray hits. And then the light ray actually hits the cornea, and the cornea is curved. Anything that's curved is going to have an ability to bend the light. Next it hits the lens. This is where the majority of what I'm going to talk about is affected. The lens actually bends the light fairly significantly, quite significantly in fact. And this is where the cataract forms. And then the next section is, so it forms a sharp point on the retina here. So the whole point of this is to focus the light onto the retina. Now, as many of you wear glasses, you know that without your glasses on, light isn't actually focused perfectly onto the retina. If the eye is too long, well, the light is focused in front of the retina, and that's called myopia or nearsightedness. If the eye is too short, it focuses behind the retina, and that's hyperopia or farsightedness. And then you have astigmatism, which is essentially where the light rays are bent asymmetrically. Excuse me, where the eye is shaped more like a football than a basketball. So it will bend on one axis more steeply and the other axis less steeply. So instead of a sharp point on the back of the eye, you actually get an oval. Obviously, the image isn't as sharp. So when the light hits the back of the eye, it actually hits, it's actually interesting, it goes all the way through the cells of the retina, and then it hits the photoreceptors. We're kind of made slightly inside out, and hits those photoreceptors. Those photoreceptors discharge, and that's the that's the electrical signal through the nerves that then is transmitted back to the brain and is then interpreted by the brain and gives us sight. So what's a cataract? Let's talk about cataracts. So cataracts are basically simple. This is a clouding of the lens. So we're all back right here to this lens. We're going to stay in this lens part for now. So a cataract it's a clouding or obscuring of light passing through the lens. And it's very, very, very common. In fact, if you live long enough, everybody will get a cataract. Many of you have already had cataracts, have already had cataract surgery. A cataract is a natural aging process of the eye. It's unfortunately like wrinkles or gray hair. No matter what you do, they're going to happen. Some people get them really early. Some people get them really late. Some people you look at and you think, you're like, that's no fair. You got a bright, huge head of brown hair. And I'm gray and I was 35. Same thing with cataracts. Some people get them at 50, some people get them at 90. So by 80, more than half of Americans have already either had cataracts or cataract surgery. And I would actually argue that at whose definition? Because by the time you're 80, you have nuclear sclerotic changes. Like nobody doesn't have nuclear sclerotic changes by the time you're 80. It's like saying that an 80-year-old doesn't have wrinkles around their eyes. Good luck. Cataracts can occur symmetrically, asymmetrically. It occurs in one eye, both eyes. But the definition, again, is going to be important in this one because the formation of the nuclear sclerotic aging change, it exists, similar to, unfortunately, the wrinkles and gray hair that exists. They don't spread. They're not contagious. The majority of the time, they're just a natural process. So how do they develop? Essentially, that clear lens that you had when you were a small child turns yellow. It turns yellow, it turns brown, it gets harder, it becomes more difficult to actually change shape. Cataract formations is one of the reasons that you lose that ability to see up close, a condition called presbyopia, which again is fortunately a very normal aging-related process. So this is a very natural thing that happens. The sharpness of the image when you have this kind of cataract, a nuclear sclerotic cataract, oftentimes the vision is maintained for years and years and years and years, which is why when you develop an early cataract, you say, I'm perfectly fine. Well, you have cataract changes, but that's, again, a normal process. Light still is able to pass through. Usually people do wonderfully for a very, very long period of time with this kind of nuclear sclerotic cataract. Some of the symptoms we'll talk a little bit later about. Loss of color vision, difficulty seeing in dim lights, glare, especially up here in Fairbanks. We'll talk a little bit more about glare and why that happens. Especially you'll have difficulty seeing the blues. Images become more dull. The cataract attenuates the light. This kind of cataract especially will attenuate the light. So light comes in and it is still able to pass through and focus, just not to the same strength that it would have in your prior non-cataractous lens. You can also have a couple other different kinds of cataracts. We're going to talk a little bit about, we talked about the nuclear sclerotic cataract. So a nuclear sclerotic cataract is very much a natural aging process. And you'll see people in their late 90s who have never had cataract surgery because they've only had a nuclear sclerotic cataract. They have a dense brown cataract, and yet they can still read 20/20 in the exam room. Now, it's impressive that they can do that. You take the cataract out, and they think that the whole world has just dramatically changed because all of a sudden the sky is blue again, the walls are white, the light is amazing. They can't believe how much brighter the world is but they can still read 20/20, and they can still read their book with a really good light source. So it's amazing what a nuclear sclerotic cataract can do and yet preserve the vision. Although vision is a lot more than just how many letters you can read on a board. There's a lot more to the quality of the vision in addition to the quantity of the vision that is affected by cataracts. This is a great example of a cortical cataract. So there are three main kinds of cataracts that I'm going to talk about right now. The first is the nuclear sclerotic. Again, very typical age-related process. Virtually anybody in this room, see a couple people back there who might not have cataract yet, but virtually everyone in this room has some sort of nuclear cataract formation, nuclear sclerotic cataract formation. You've either had them removed or you haven't. And again, totally normal, natural aging process. Cortical cataracts, they developed more rapidly. They tend to be more visually significant earlier on. They tend to be extremely glary. So as light comes into this, you can, just looking at the photograph, you see a lot of glare coming off of it. It's essentially the light comes in and it hits all of the particles and it sets it off kind of like a disco ball. And so obviously the light isn't going to penetrate through the eye nearly as well. When the eye gets dilated, when the sun hits it, extremely glary kind of cataract. Now again, you can look at this cataract and that person can be 20/20. I'm sometimes amazed at people who are 20/20, 20/25, and you look at that eye and you just, wow, how can you see through this? You shine a light in your eye and they can't see the big E anymore. Extremely common when that happens. So these ones tend to develop a little bit more rapidly. More importantly, they become symptomatic earlier. And that's really the key thing is, what's the value of a cataract? What's important about a cataract? It's when does a cataract become symptomatic? You don't do anything about them until they become symptomatic. I'll talk more about that later. Posterior subcapsular cataracts. These ones actually, the cataract forms on the back surface of the lens. I don't really have a picture of it because they're very hard to photograph because they're on the back surface of a lens. So these ones unfortunately grow very rapidly. When someone says, yeah, my cataract came on in 2 weeks, 3 weeks, that's a posterior subcapsular cataract. Unfortunately, it tends to hit a slightly younger population. So people in their 50s, early 60s, sometimes even 40s, when they come in, that's the kind of cataract I expect out of them. Why that happens? There are reasons for that to happen. Sometimes if they've had exposure to steroids or radiation, certain medications, certain surgeries, and then there's just happens, bad luck. On the bright side, it's relatively easy to treat. So, who's at risk for cataracts? Basically, anybody who has birthdays. As we get older, cataracts will form, period. It's going to happen. Certain conditions, certain diseases, such as diabetes especially, it tends to happen sooner. There's a special diabetic cataract, which is, we'll talk a little bit more about later, but cataracts happen if you have any metabolic issues in the eyes. Generally, poor health tends to have cataract formations earlier than others. Certainly being exposed to radiation, having prior surgeries, those all will absolutely cause cataracts. Prior eye surgery, I should say. Any radiation hits the eye, the lens absorbs it like a sponge, so you definitely get cataract formations from that. Personal behaviors, smoking, excessive alcohol use, exposure to light, people who've had a lot of UV light exposure, especially sunlight, they tend to get cataracts sooner than others. So what are the symptoms of cataracts? This is a little bit of a busy slide, but basically there's lists and lists and lists of symptoms of cataracts. Essentially, things get blurry, difficulty seeing in dim lights, colors are faded, and remember this happens so slowly that oftentimes people get to fairly advanced stages not having realized it until I take a cataract out of one eye and they say, oh my goodness, I can't believe how bad my other eye is. I have no idea because it's like watching a small child grow. Day to day you don't see it, but when grandma comes to visit, I can't believe how much she's grown. So some of the other things that happen up here especially is poor night vision. And glare is a huge issue. One of the reasons we have such issues with glare in Fairbanks is because during the summertime, the sun never gets off the horizon. So sun right in your eyes all the time, the entire time. It's not like you're in Los Angeles where it goes up above your head. In Fairbanks, it stays right in your eyes the entire time. We actually have the highest per capita sales of sunglasses as a result of this because it's always in our eyes. Additionally, during the winter time, unfortunately, we're driving at nighttime. There's no avoiding in night driving. So it's nighttime at 10 a.m. and it's nighttime at 3 p.m. So your pupils dilate. All of those aberrations that we see from the cataracts, as light comes in and hits that, it actually will diffract it and basically not able to focus that light onto the retina anymore. And so you get terrible glare. In Fairbanks, driving is a huge issue. About September, October, there's a big group of people that come in saying, I can't believe the headlights are this big, they weren't that big last year. And it's because of the glare issues and driving at nighttime. So additionally, you can get double vision in the eyes. I want to put a little caveat on this one just so if anybody happens to get double vision, that this is one eye double vision. This is a really key difference. If you cover one eye and you see two images or a shadow image or a ghost image from one eye, that is the kind of the double vision that you get from cataracts. If you see two sharp images of me, you cover one eye and the image goes away. You cover the other eye and you only see one, and you only see two when both eyes are open, that is not cataracts. You need to go see somebody immediately for that because that is neurologic-based double vision. So this is monocular double vision. If you ever get double vision, see is it one eye or is it two eyes? So if it's only present with both eyes open, that is not cataracts that needs to be evaluated. If it's present only with one eye open, then it could be cataracts. You still want to have it evaluated because double visions are really important. It's very important and could be a sign of many other very, very, very important neurologic conditions that need to be diagnosed. So another thing that people come in talking about is that their glasses prescription keep changing. I had this glasses prescription for 2 years, and then I had to get it changed in a year, and then I had to get it changed in 6 months, and then I had to get it changed in 3 months. This is terrible. The glasses are wrong. But it's actually not the glasses that are wrong, these are cataracts that are forming. One thing that can happen with cataract formation is you actually get progressively nearsighted, which is interesting because if you happen to be farsighted to begin with, you actually will get second sight. Or if you were normal, you would be able, or not more plano we call it, so you don't need glasses, that you actually will be able to come nearsighted and be able to read again, where you previously needed reading glasses for it. So that, we call it a myopic shift. Your nearsighted shift actually is a very classic sign of cataracts. And that's actually because the material of the lens actually changes in chemical nature and it bends the light differently. So this would be an example of what normal vision is and vision with cataracts. So this gives you an idea of essentially what it would be. Again, in Fairbanks, we have much more glare symptoms up here, and so people actually get their cataracts taken out, I find, a little bit earlier than they did down in Florida, because in Florida the sun was above their head, we didn't have the glare issues that we have up here. And up here, the number one symptom every time is glare. So what are the other kinds of cataracts? So we talked about the three main kinds, but there are a whole bunch of other kinds of cataracts. We talked about cataracts after surgeries, the glaucoma and retinal surgery specifically. The use of steroids, specifically topical steroids and intravitreal rather than the oral steroids like prednisone that some people might be familiar with. Diabetics cataracts. Sometimes diabetes, obviously, as you guys know, high sugars. Those high sugars can actually cause osmotic changes in the lens itself, and you can actually get what's called a flash white cataract. So the sugars are so out of control that it basically hydrates the lens overnight, and people will wake up with a white cataract. I mean, bright white. You'll look in their eye, and it will look white. And that's a classic diabetic cataract. Again, talked about radiation, traumatic cataracts. Now, these is a different ballgame. When you've had trauma to the eyes, it can actually cause a blunt force. You can actually see a little contusion. When that happens, unfortunately, one of the things that can happen is it can damage those zonules, those fibers that hold the lens in the center of the eye. So having a trauma history or letting the doctor know, listen, I had a really big injury, I broke my orbit or whatever the case may be, that's important because sometimes those fibers don't actually hold that lens in the center of the eye anymore and they're unstable. Congenital cataracts, when you have a big congenital cataract, like born with a big white cataract, that's a huge issue. Those children tend to have very poor vision, very, very poor visual outcomes. You have to have surgery within a couple of days just to be able to give them the hope of any kind of sight. I do not treat those, luckily, because they're very sad. Small cataracts that are congenital cataracts, you can have a little lamellar cataract in there, and some people have seen me for lamellar cataracts. Those are usually relatively asymptomatic. People generally tend to do very well with those, and honestly, they don't need to be treated. Posterior polar cataracts, we talked about those blood vessels that grew from the optic nerve into the front, and they actually formed the front part of the eye, and then they regressed back. Posterior polar cataracts are where they basically didn't regress all the way, and there's a leftover little scar tissue right there at the back of that lens bag, and those can be difficult because the bag itself is congenitally open. So there's a hole in the back of the bag. So you take the cataract out, and there's a hole between the front part and the back part of the eye. And that's specifically something we try to avoid, making that hole. So let's talk a little bit about how cataracts are treated. So they are an anatomic entity in the eye. In order to change anatomy, you need to do surgery. So surgery is the only way to treat a cataract. Unfortunately, the drops, vitamins, there's nothing that helps cataracts at all. Once you have a cataract, you have a cataract. So when do you do cataract surgery? And the answer is when it is symptomatic enough to warrant doing surgery. Cataract surgery is a very, very, very low-risk surgery. It's extremely low risk. It's a great surgery. That said, no matter what you do, it's surgery, and it has risk associated with it. No matter how low the risk is, if there's no benefit to doing the surgery, well, the risk is going to be too high. So you do surgery when the benefits outweigh the risks. And luckily, with a very low-risk surgery, your benefits don't have to be hand motion vision or barely or essentially blind to be able to have your cataracts taken out. You need to have symptoms that affect your activities of daily living. The state of Alaska has guidelines. Different states have different guidelines. Some people you have to have glare vision worse than 20/40. The state of Alaska says if it bothers you and you want to have surgery, it's good enough for them. And the purpose of this is actually to have insurance pay for it. And that's what these guidelines are for. Is when is it deemed medically necessary, such that Medicare, Medicaid, Blue Cross, any of the others will pay for the surgery. Incidentally, delaying surgery. If you have a cataract, cataracts in and of themselves don't hurt you. You're just not going to see any better until you get rid of them. With a rare exception, there are a few conditions in which the cataracts themselves become pathologic. Usually those are very advanced stages, or they limit your ability to see the retina to treat other diseases. And those are medical indications for treating cataracts, but those are very rare, usually the exception rather than the rule. So, techniques. I didn't put a video in here because not everyone really likes watching videos of eye surgery. I thought about it, I almost did. But some people get squeamish about eyes. So I didn't put it in. So there are several techniques, pretty much only one of which is done in the United States anymore. And that's phaco emulsification. The extracapsular cataract extraction, that is pretty much not done anywhere, and certainly in the past decade. It's barely even taught as a technique anymore. It was the technique 20 years ago, but certainly not now. It's a technique in the developing world, for sure. Phaco emulsification is essentially where we take a very small, round little cannula. It's needle-ish, but it's only needle-ish because it's so tiny. And it's actually connected to an ultrasound device. And this ultrasound device essentially emulsifies the lens. It breaks it into a million pieces, sucks it through that little cannula, and goes away. So phaco emulsification, phaco is the Greek or Latin for lens, and emulsify. So essentially emulsification of the lens itself. This is done through a teeny tiny little incision in multiple different areas. I personally do an incision through the cornea because it's extremely fast healing and requires very little anesthesia. A couple different ways that anesthesia is done. Topical anesthesia is done with either topical lidocaine jelly or several other different concoctions. You can do a peribulbar injection or a retrobulbar injection where you essentially stick a needle blindly in behind the back of the eye and numb that area. I don't do it, so it is still done, unfortunately, quite frequently, and certainly in the state, actually, very frequently. Intracameral, a little bit of intracameral anesthesia. I do a little intracameral anesthesia as well, which plus or minus whether it's needed, but it does help the pupil stay dilated a little bit. My personal technique is called topical clear cornea. It is the most common technique taught now. Pretty much anyone trained in the past decade does it this way, and most everybody has turned over to topical clear cornea because it is incredibly successful. The topical clear cornea allows topical anesthesia only. That means no retrobulbar injections, no peribulbar injections, no risk of hemorrhages behind the eye, no risk of globe perforations, no risk of any of those things, no induction to anesthesia, which causes risks for your heart, your lungs, kidneys, all the things associated with anesthesia, especially in the aging population who oftentimes have cardiac issues. The less you can do, the better it is for the body. So this is a 2.4 millimeter self-sealing 3-layer incision. You go in, up, and in, and the pressure of the eye itself actually maintains the wound being closed. It's sutureless. Again, a little bit of sedation oftentimes is needed. Well, I personally, if you're in a full-body drape for sterility, and if anyone put me in a full-body drape, they better give me some happy juice. So we have anesthesia there in the room to give happy juice, titrated to whatever you need. Some people actually want to see the pretty lights, and some people want to have no memory whatsoever. And so that can be accommodated. The surgery takes about 10 to 12 minutes. So it's an incredibly fast, incredibly reproducible, excellent outcome surgery. I'm sure many of you have had, I've seen several of my patients here that have had cataract surgery. It's a fantastic surgery. I wish I could say I invented it. I love doing it. It is an absolutely fabulous, successful surgery. People have fantastic outcomes with it. So what are the risks? So like I said, surgery is surgery is surgery. No matter what you do, no matter how low risk it is, it's still risk. There's still risks involved. So the risk of infection nationally is 1 in 1,000. I put an antibiotic in the eye at the end of surgery that actually kills 95% of the bacteria that cause infections. It's a 100% kill rate for this group called a gram-positive bacteria. 95% of bacteria, or 95% of infections are caused by this class of bacteria. So the risk for my patients is 1 in 1,000 minus 95%. It's a very, very, very low number. It's not 0, it's just a really, really, really low number. So that's the risk of infection. That's usually the worst, most catastrophic events. Infections are, the eye is essentially a petri dish, so catastrophic events in the eye. Retinal detachments. Risk is about 1 in 1,000, and there's not much we can do about that one. It is what it is. The risk increases if you're very, very nearsighted, increases if you're very young, decreases if you've already had the jelly separate from the retina. So my technique that I specifically use is a bloodless technique. So there's really no risks for hemorrhaging, no risks for bleeding, so there's no reason to stop your blood thinners. You can be on Coumadin, Plavix, Agranox, name it, and no problem at all. Sometimes, occasionally, you can get some swelling of the retina or swelling of the cornea, and then every once in a blue moon, crazy things happen, like a stroke in the eye. Extremely, extremely unlikely. Not even a large enough number to be able to put, a large percentage to be able to put an adequate number up here, because it's so rare. Will my vision be better after cataract surgery? Almost always yes. The key thing to remember is that cataract surgery only fixes the vision loss due to cataracts. So if you have glaucoma, macular degeneration, other retinal problems, it's not going to fix those because all it's going to do is fix the vision loss due to cataracts. So one of the things we want to talk about is what will your glasses prescription be after cataract surgery? So cataract surgery, the lens choice, we take all these fancy measurements, and believe me, I have all the fanciest equipment that I have to keep updated, and it's, we got all the good stuff there, but nothing is perfect. Nothing is 100%. And there's a bell curve of what the lens selection would be for each individual person, and unfortunately, people fall off the bell curve line. So my numbers are about 80 to 85% are able to hit the target within half of a diopter. So I aim for you to be just inside of infinity, which is where most of the world is, and about 80 to 85%, which is true, 80 to 85%, we're able to hit that within half of a diopter. But not everyone listens to the books, and some people fall off the bell curve because their eye reacts differently than the average eye. And so no results are 100%. Also, we need to treat astigmatism. And there's a couple different ways that we can treat astigmatism. We treat astigmatism with toric lenses, which is an astigmatism amount that's actually impregnated in the lens aligned to your anti-axis. The idea being +1, -1, net result of the eye is 0. You also do a relaxant incision where you actually change the shape of the cornea a little bit, and that can help affect the improving astigmatism amounts. Everyone after cataract surgery will need reading glasses. Almost everyone, with the rare exceptions. But we aim for you to be at one distance, which usually people prefer to have distance vision, and then you need reading glasses to be able to see up close. Okay, so what do you do if you have cataracts? Go see your eye doctor. And they will, usually the optometrists in town are pretty good about being able to see when it is that you are ready to have surgery. But remember, the answer is symptomatic. You don't have to ripen a cataract anymore. The ripening of the cataract was back when you actually did an extracapular extraction, where you had to be able to take that lens and pull the whole lens out of the eye through this massive 11-millimeter wound. I mean, it's just huge. Now we go through a little wound. And so softer lenses are actually perfectly fine to take out. So the answer to when you have cataract surgery is when you have symptoms warranting having cataract surgery. And that's the answer. So what can you do to protect from formation of it? Well, we're all getting older. So you can try wearing sunglasses, eating a healthy diet. There's variable questions about whether or not a multivitamin helps. Unfortunately, those really fancy topical eye drops do nothing. But, do the best you can to eat a healthy diet, live healthy, don't get all the diseases associated with it, and wear sunglasses. And that's cataracts. Any questions about cataracts? Yes?
Once you have had cataract surgery, can it be required again?
One surgery per eye per lifetime. Done forever. I'm actually taking the lens out. It cannot grow back. What can happen, though, is some cells can grow along the back part of that bag, and that can actually cloud the back part of the bag, and so people get what used to be called a secondary cataract, which is now called a posterior capsular opacity, or a PCO. Those cells along the back part of the eye can give very similar symptoms to cataracts. Those are treated in the office with a laser that takes about 15 seconds, and again, one laser per eye per lifetime. Yes, sir?
How has technology changed the lenses, say, over the past 15 years?
15, let's see, this is, I would love to tell you the story behind it. If you wanted during later in the, I will tell you this super fantastic story about how the lenses happened. They've actually changed dramatically and fairly fantastically. So the first lens was polymethylmethacrylate, PMMA, and we're now using acrylic lenses. And the acrylic lenses are softer, they fold up, which allows them to go through a 2.4 millimeter wound. And they basically formed up like a taco and inserted, and then they open up, and then these little haptics come out and brace itself against the bag. The lenses are fantastic. They're aspheric, they're blue blocking. A lot of the things that we do to maximize things now, in terms of the eye, blue blocking lenses protect your retina from ultraviolet rays and specifically prevent or help with macular degeneration and all the other aging processes of the retina. The acrylics are very well tolerated. The haptics have different edges that has dropped the incidence of the posterior capsular opacities from 100% to 25%. So 75% decrease in that. Fantastic lenses. There are a few things that are coming up, but none of them are even close to market. I mean, 10, 15 years before market. There's a few things that were tried and were removed. Yes?
When the lens comes out, I suppose most of them are flushed, thrown away. So here's a question. Has anybody ever found a use for the old lenses and removed, for example, any stem cell activity? Is there any use, something could be done with this? Or
the way the lenses are taken out now, the way they're taken out now, they're not. It's basically dissolved into fluid. Previously, they were taken out in toto, whole lenses, and I mean a long time ago they had intracap and they kind of popped the lens out, which would be malpractice now. But I don't think anything's not that I know of. I'm sure research went into it, but not that I know of.
The radiation, is it anywhere in your body or just to your eye?
Usually around the eyes. It has to be usually the head or eyes.
So the Restasis products that are a steroid, how do those impact cataracts later on in life?
Actually, great question. It's because Restasis actually isn't a steroid that it actually does wonderfully. Taking long-term topical steroids will absolutely cause cataracts, and that was one of the reasons that Restasis kind of came about, is because it's actually low-dose cyclosporin, which is a non-steroid, it's a steroid-sparing anti-inflammatory agent. Initially, it was actually a chemotherapy agent, but then they diluted it down to such microscopic levels that there's no systemic chemotherapy effect to it anymore, but there's a local anti-inflammatory effect to it. So luckily, no, Restasis does not cause that, thank goodness, because that'd be a big issue. Yes?
Okay, there's an interesting. I was being treated for glaucoma,
Mm-hmm.
and then I got to the point where I had my cataracts removed, and for a while then the pressure was down and I didn't need to take anything. Why does that happen, you know?
Absolutely. A couple things, we'll talk a little bit more about that in glaucoma. I'm going to bring this up, yeah.
I'm taking drops now, but that's
Right.
over 17, 16, 17 years old.
It is now incredibly well described that cataract surgery actually decreases intraocular pressure. And one of the reasons it does so is because it actually opens up the space in the front part of the eye, because you're taking out essentially a three-dimensional structure and putting in this teeny tiny little acrylic lens in there. And so everything has more space. So the iris sits back, the angle opens up, the uveal outflow, which is one of the ways fluid gets out of the eye, is actually more readily available. Tons of anatomic changes within the eyes, especially in patients who have narrow angles in the front part of the eyes, and we'll talk a little bit more about that, what narrow angles are. But it's actually an interesting thought, because the interesting topic you brought up, the glaucoma groups and the cataract people that are out there and that are kind of setting the protocols for the world are really thinking about one of the first glaucoma surgeries being actually cataract surgery, because there's sometimes as much as 8 pressure point drop just by having cataract surgery. But certainly in almost everybody, there's at least several pressure points of drop after having cataract surgery. So yes, it's very, very well described. And mostly anatomically, this is stuff we talked about, but yes.
And I was one of those lucky ones maybe that could get by without reading glasses, except up real close.
Lucky you.
And nothing after, since 3rd grade.
Good for you.
More glasses, and so
Lucky you.
it makes my eyes so well.
Fantastic. Did you have a question?
I did get eye surgery before. This is prehistoric times. It was about 15 years ago. They didn't have them up here at the time. And I was so enthusiastic, I thought I'd never need glasses again. So I got it done down in Limey, Columbia. Oh, British Columbia. I call them Limeys, I guess. But anyway, so does that mean I can't have a surgery again, 20 years later, 15 or whatever?
Once your cataracts are out, they're gone.
Once
Once your cataracts are out, they're gone.
I think that's what they did anyway. I don't know.
I have to look into your eye to be able to see that.
Okay. I don't want to read that. But anyway, so for a visit like you, what's the schedule? Just a visit for to inspect your eyes?
Mm-hmm. Yeah, you can see in our office, you probably see Dr. Reinschmidt, who's an optometrist, to take a look at the eyes and see how they're doing. And usually if you get kicked over to me, it's because you need surgery or there's something bad or you need to have something figured out. So, but that's generally the way we do it here.
Okay, thank you.
You betcha. Mm-hmm.
You have this one, you take the lens out, right? Then you have to put something in, or you just leave?
No, we put in a lens. We measure your eye to put in an artificial lens, an acrylic lens, that is able to focus the light onto the retina. There's kind of two ways that we are able, and that one of the things about cataract surgery is you have the ability to get you out of glasses. And that's an amazing thing. It's fantastic. It's similar to LASIK, but LASIK actually changed the shape of your cornea, and I changed the power of the lens. So if we go all the way, so if we go back here, so if you look at this section, as the light rays come in, it's bent by two main surfaces. So it's bent by the cornea, which is where LASIK comes in, and they change the shape of the cornea to focus the light more perfectly onto your retina. And I actually change the lens. So I take out this lens and I measure your eye, your cornea, where it sits in your eye, and we throw in this very long calculation about what lens is going to focus that light perfectly onto your retina. And that's the part that not everyone has exactly the same thing. And I'm taking out this big three-dimensional. Again, I put in this teeny tiny little skinny thing right in there. Where that sits in that potential space is going to determine what your end outcome is. So I can measure absolutely perfectly. It is perfect, and it sits in there. And you heal a half of a millimeter that way, and that's a diopter and a half of nearsightedness or farsightedness. So, but again, the measurements we have, most people fall into the algorithm. And we have fantastic outcomes because the measurements are very, very, very sophisticated, and the formulas are fourth generation formulas, huge back analysis. So the outcomes are actually extremely good in terms of getting people functionally out of glasses. Let's go ahead and move on to glaucoma, because we have two more topics, and I'm noticing that time is running out very quickly. So glaucoma. Glaucoma, in a nutshell, unfortunately, is quite scary. Glaucoma is asymptomatic, progressive, irreversible, and blinding. This is a very, very scary condition. So this is a group of conditions that damage the optic nerve. So there's actual damage to the brain tissue. The signal that goes to the brain is what's damaged. It is associated with high pressures, but not always. So let's talk a little bit about normal flow. We talked about the ciliary body back here is where the fluid is made. The fluid then passes between the lens and the pupil. This is why when you take the cataract out, there's more space for everything, and the pressure goes down. So it travels between the lens and the pupil, and then goes out through that angle, an area called the trabecular meshwork. That goes into Schlemm's canal and goes back to our lymphatics and recirculates. What's angle closure? So we're going to talk a little bit about angle closure glaucoma and open angle glaucoma. Most of the people, when they talk about glaucoma, they're talking about an open angle glaucoma. Closed angle glaucoma is a really different beast. Acute angle closure glaucoma is an absolutely catastrophic event to the eye. The angles close up. Essentially what happens is the iris right here touches the lens, it gets stuck. The fluid is made behind the lens. You get this big Bombay of iris that comes out. It closes the angle off even more. the pressure goes up to 60, 80, you're in agonizing pain, vomiting, absolute misery. You come into the emergency room, your eye is hurting so badly you can barely even stand it. That's angle closure. Your pressure is 80, you go blind in 2 days. So this is an absolute medical emergency. So luckily, we haven't had an enormous number of them up here, but they're ugly when they happen, and they're extremely difficult to treat when they happen. Because everything, the whole eye just gets angry, the cornea swells up, the iris swells up. The way you treat this is you open up a hole in the iris to allow that fluid to equilibrate between the front part and the back part. Incidentally, this is about that easy to prevent. So, but you need to have it evaluated. And this is a really big thing up here. So you need to have something called a gonioscopy. So they actually put a little lens onto the top of your eye, and they actually, with mirrors, look at the angle. You can't see the angle of the eye. You can't actually see through the cornea that far into the periphery of the cornea to be able to see the angle of the eye, to see if the angle is open or closed. What you need to do is you put that lens on, you look through a mirror, and you're actually able to see, is the angle open or is the angle closed? If the angle is closed or occludable, you need to have a hole put in the iris to prevent this catastrophic event from happening. So this is super duper duper easy to treat, an absolute disaster if it happens. So if no one's here had a gonioscopy, come see my office, we'll do a gonioscopy. I do this all the time. So you have to have an evaluation of the angle of the eye. As you get older, that lens grows and grows and grows, and it grows forward, and it actually gets closer, and it pushes that iris forward. And so acute angle closure is significantly higher risk in an elderly population. It doesn't happen in people my age, it happens in people your age. So once you've had cataract surgery, incidentally, you're not going to go into acute angle closure glaucoma. So all of you have had cataract surgery, don't worry about it anymore. Chronic angle closure glaucoma is where instead of going into an acute angle attack, the iris is stuck up against it, and it just stays there. And it just gets stuck. It gets glued to the end, and it actually will block that meshwork. It basically blocks the drain from forming. And so this is chronic angle closure glaucoma. This isn't something that happens. This is not the catastrophic acute event. It is a very difficult, very aggressive form of glaucoma that was 100% preventable by a laser, by gonioscopy and a laser. Incidentally, up here in Alaska, the Inuit population, Inuit and Eskimo population, have statistically the highest risk of angle closure in the entire world. It is well published, and in fact, all my friends ask me about that because I'm in Alaska. Oh, do you see the Inuit population? Do they really have angle closure? Yes, they do, as a matter of fact. So what's open angle glaucoma? So basically, the angle's open, so why can the fluid get out? You have microscopic debris that is actually put in the intracellular space in that trabecular meshwork that is mechanically blocking the fluid from being able to leave. It's a basic plumbing problem. So the drain is getting blocked, but no one's turned the faucet off, and so the pressure goes up. And the pressure goes up, and the pressure goes up, and it happens over time, and it happens slowly, and there's no symptom. No one feels glaucoma. No, people will feel it if your pressure is 80, but nobody feels a pressure of 30, 35, 40. So basically what you have basic plumbing. What happens with that is that elevated pressure actually overpowers the perfusion pressure into the eye. So we have an ability that our blood pressure is what forces the blood into the different tissues, correct? Right? Everyone understand the concept of blood pressure. Pushes the blood around, that blood pressure keeps the fluid moving in the direction, goes into the tissues, serves the capillaries, gets to the cells, et cetera, et cetera. If you have too much back pressure on that, it can't perfuse anymore, it can't go anywhere. So that's what happens in glaucoma, this is one of the mechanisms that they think is what happens. There are several other mechanisms as well, so it actually mechanically pushes the nerves against the plate in the optic nerve. But one of the key mechanisms is that pressure perfusion ratio they call autoregulation. Sometimes you can increase that pressure and be able to push through that perfusion, that intraocular pressure. But at about 30, everybody breaks down. Everybody gets glaucoma. So what's normal tension glaucoma? Well, normal tension glaucoma is glaucoma, open angle glaucoma, with pressures of 17. Why it's totally normal pressure? Why does someone have a pressure of 17? And basically, it's the route the other direction. Their perfusion pressure isn't good enough. That even normal pressures are too high and they can't get the blood flowing. It's a blood vessel disease rather than a high pressure disease. But unfortunately, the treatment's the same. The treatment is to lower the pressure. The problem is lowering the pressure from 17 to 12 is very difficult. I can get you from 40 to 20, piece of cake, well, relatively. But there's a lot more I can do to get you down from 40 than I can down from 15, 16. So it's unfortunately more aggressive as a result. What's ocular hypertension? So ocular hypertension is high pressures without actually having nerve disease. So your nerve is actually able to maintain its perfusion, maintain its health, despite having elevated pressures. Now there's a big study called the OAT, the Ocular Hypertension Treatment Trial, the treatment study, that showed that the 5-year risk of developing glaucoma actually dropped by more than half if you treated it. If you had a 30% reduction in pressure, your likelihood of progressing to glaucoma actually went way down. So now we also have to talk about corneal thickness. The way this pressure is measured is you're actually slightly indenting the cornea. When you indent a thin cornea, it's easier to indent, right? So the pressures are going to seem like they're lower where they actually were higher. If you have a thick cornea, it's going to be harder to indent, and so you would imagine pressures are actually going to be measured higher than what they actually are. So that's called central corneal thickness, and that can account for some of the ocular hypertension. Incidentally, it's also an independent risk factor for the development of glaucoma. So that's an important thing to know. But for your doctor, more important. So are there different kinds of glaucoma? Lots and lots of different kinds of glaucoma. Open angle, acute, chronic, pseudoexfoliative, pigmentary, juvenile, adult onset juvenile, normal tension, angle recession, lots of different kinds of glaucoma. So when people talk about glaucoma, not all things are created equally. There's tons of different systemic diseases associated with glaucoma, et cetera, et cetera, et cetera. I'm going to point out a couple things. These two right here, pigmentary glaucoma and juvenile open angle glaucoma. The key thing is they do not actually happen in your age group. They happen in my age group and younger. So this is one of the reasons that people in my age group, your children, your grandchildren, actually need to have eye exams as well, is because especially this pigmentary glaucoma, I have a lot of pigmentary glaucoma patients in their 30s. I have a lot of pigmentary glaucoma patients who have advanced disease, irreversible blinding, advanced disease in their 30s because they're undiagnosed pigmentary glaucoma. No symptoms. Juvenile open angle glaucoma, hopefully, I've only seen a couple because it's a terrible, terrible aggressive glaucoma. Neovascular glaucoma associated with diabetes, associated with having strokes in the eyes. Most of these, if you stay in the system and get routine eye exams, a doctor should be able to evaluate for these things. What are the symptoms? That's the scary part. There is no symptom for glaucoma until very, very late in the disease. This is the scary part of glaucoma. This is why you have to have regular eye exams, and encourage your friends and family, even the young ones, to have regular eye exams, because most of this stuff is diagnosed very easily if you look into the eye, but extremely difficult if they're never seen. So, who's at risk? Everyone. So anyone who's getting older. African Americans especially, and risk factors including if you have a family history of glaucoma, any history of elevated pressures, any increased cup-to-disc ratio. If you have thin corneas we talked about, that's an independent risk factor. If you have an abnormal anatomy of the optic nerve. But a family history of glaucoma is a big one. If you have a family history of glaucoma, you need to have this evaluated and taken seriously as well. So what does vision loss from glaucoma look like? This is what people used to think about it, but actually it looks like that. We all have a physiologic blind spot. Every single one of us has a blind spot. It's where the optic nerve goes back. There's no retina at the optic nerve. How many of you see your blind spot on a regular basis? Nobody. No one sees their blind spot. The brain fills it in. So this is what happens in glaucoma. The brain fills in your spots. And so you don't notice it until you've lost so much that everything starts becoming dim and dark and very blurry, and you're at end-stage disease. This is the scary part of glaucoma. How is glaucoma detected? So you need to have an eye exam. And more importantly, going in and having your pressure checked does not count as an eye exam. They need to look at your optic nerve. Additionally, going in and having someone sit in the waiting room and tono pen with this little thing your eye and tell you your pressure is 18, you're fine, Mrs. Jones. No, that is absolutely not how glaucoma is checked. Glaucoma is not checked by going in and having a puff tonometer and telling me your pressure is 5 or pressure is 15. Both of those are absolutely inappropriate ways of evaluating for glaucoma. Glaucoma needs to be evaluated for by a doctor looking at your optic nerve, number one. Additionally, applanation tonometry. So the puff does not give adequate readings. The tonopen does not give adequate readings. Those give ballparks. The ballpark with a puff, plus or minus 7 or 8. The ballpark, the tone pen, plus or minus 4 or 5. Plus or minus 4 or 5 is not good enough for glaucoma. Applanation tonometry is the gold standard, and it's the only way it should be done. Gonioscopy. Everybody should have a gonioscopy. If you have glaucoma, you need to have your angles checked. If you have chronic angle glaucoma, you need to have an LPI. If there's a whole bunch of different things that they only can be evaluated if you actually have a gonioscopy done. You have to have your optic nerve evaluated. So you have to have a doctor who knows what an optic nerve is supposed to look like to look at your optic nerve and say if there's an anomaly or if there's an abnormality. So you also have a whole bunch of ancillary tests. This is a visual field. It evaluates for a classic pattern of visual field loss in glaucoma. That would be, unfortunately, a very classic visual field pattern loss in glaucoma. This person had a significant chronic angle closure glaucoma. Corneal thickness of the pachymetry. That, again, like we talked about, allows for correction of your pressures as well as a risk factor for whether or not you're more likely or less likely to have glaucoma in the early stages. And so, nerve fiber layer. This actually measures that nerve fiber layer that goes to the optic nerve and measures the ring around it. And you can usually see a pattern of nerve fiber loss. We tend to lose the nerve fibers in glaucoma from the poles, so the top and the bottom. And you can see this is a great example. She had one very normal eye and one eye with advanced disease, where she had significant, we call it vertical thinning. So this retinal nerve fiber layer also has progression analysis. So it has microscopic analysis, far better than the human eye, to be able to see, is this progressive? Remember, glaucoma is a progressive disease, so it's one of the hallmark features. Ganglion cell, again, measures another form of that has progressive loss. We don't yet have progression analysis for ganglion cell, but it's coming. So, but the key thing is also optic nerves. We need to look at the optic nerves. We need to look at them in sequence. So this is a great example. You can see the nerve on the left here actually still had a cataract in. That's why the picture is blurry, is because there's a cataract in front of it. So the person sees blurry out and we see blurry in. So you can see here that the comparison between the two. And more importantly, we can do these in stereo. So we actually, with a little stereo viewer, I can actually see 3D. And so I can actually put a 3D image from a year ago and a 3D image from now, and I can look and see, is there actually progression? And most people don't like me staring at their eyes for 2 minutes to be able to see if there's any evidence of changes, but no problems if I sit there and stare at their stereo disc photos. So what is cupping? People talk about you have a cup to disc ratio. My nerve is cupped out. What is a cup? So there are over 1 million nerve fibers that travel through the optic nerve back to the brain. The cup is where there aren't nerve fibers. So 1 million nerve fibers through the disc. The cup is where those nerve fibers aren't. So if you have a large cup, the concern is that you've lost nerve fibers. So that's what the cup to disc ratio. So if you have a high cup to disc ratio, normal cup to disc ratio is 0.2 to 0.6. So if you have a high cup to disc ratio, the concern is that it's because you've actually lost nerve fibers. Doing asymmetry of the cups. So you look at the left eye, you look at the right eye. The right eye is 0.2 or 0.3. The left eye is 0.6 or 0.7. That's concerning for glaucoma. We're supposed to be symmetric. Now, not all of us are, but we're supposed to be symmetric, and certainly in our optic nerves, we're supposed to be essentially symmetric. So if there's an asymmetry, you become a glaucoma suspect. So the key thing about glaucoma is that you need to have a low suspicion for it. If you're concerned that someone has if you see any signs of glaucoma because it is asymptomatic, progressive, irreversible, and blinding, you need to have a low threshold to be able to say, yes, I'm concerned about you, let's get the studies done. And unfortunately, you have to repeat them. And they're really annoying to do, and I apologize for that. But the answer is you have to repeat them. Why? Because it's progressive. So if you progress, then this is glaucoma. If you don't progress, you stay glaucoma suspect. Or maybe eventually get taken off. Actually, you're perfectly fine. You just have a slightly asymmetric disc after 15 years. You're fine. Don't worry about it, unless it changes. So, and having an increased cup to disc ratio in and of itself, even if you don't have glaucoma, is a risk factor for the development of glaucoma in the future. And glaucoma increases with age. So the likelihood of developing glaucoma is higher, even if you've been told, I've got a high cup to disc ratio, I'm fine. Your likelihood of progressing is still higher than the average population. So we have to repeat these. We take slices in time and we look what the progression is. Is everything stable or are things getting worse? If things are getting worse, then obviously we want to do something about it because it's irreversible and blinding. So this is why we have to repeat those. And they're not fun to take. My mom has to take them every 3 months and she gripes and moans, But you know what? She still takes them, and we gotta keep an eye on it because that's what we do. So how do you treat glaucoma? So the number one thing is drops. So drops, 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 and drops. Anyone who's ever had glaucoma is on lots of drops, and they work. There's 4 different categories. One is you have a beta blocker, you have an alpha agonist, a carboxylate anhydrous inhibitor, and prostaglandin analogs. The prostaglandins are fantastic because they're a once-a-day drop. Compliance becomes an issue because when you're taking 4 drops, 2 or 3 of them twice a day, that's really hard to do. So they have combo drops. They're extremely expensive. As I'm sure many of you know, glaucoma drops tend to be very expensive. So they try to make as few drops as possible, but the answer is usually drops. There is a laser out there called a selective laser trabeculoplasty, or SLT. It actually, what it does is it stimulates the immune system to come in and clean up the trabecular meshwork and try and get those little proteins that are clogging the drains, get them to go away. We talked about that laser peripheral iridotomy that prevents the ankle closure glaucomas. Like that, it's a 30-second laser, and that whole risk is done. So the LPI is a fantastic laser. Does nothing for open angle glaucoma. So if you have open angle glaucoma, it's not going to help you at all, I'm afraid. Selective laser trabeculoplasty might, and one of the things that is being advocated by a bunch of groups is to actually do SLT first, because it is on a global society much less expensive than being on Zalatan or Trabatan for 50 years. Doing a laser one time and you get the same effect of, and it usually lasts about 5 years and is reproducible. Surgery. So unfortunately, when you need it, it's there. Glaucoma surgery is not the best surgery. I'm not going to lie to you. It's not a fantastic surgery. It is what it needs to be when you need to have it, but cataract surgery, in, out, done, great outcomes. Glaucoma surgery is a roller coaster. So there are all sorts of things to try and avoid having to do the main glaucoma surgeries, which is trabeculectomy and tube shunts. What these 2 surgeries do is they open up a pathway from the inside of the eye to the outside of the eye. Lots of danger and risk associated with that, lots of pressure instability associated with that. But when you have progressive irreversible blinding disease and it's getting worse and nothing else works, well, you have what you have. There's a few things coming up called the minimally invasive glaucoma surgeries. They're coming up. None of them are fantastic, but they're starting to get there. The iStent is probably the most promising. So what do you do if you have glaucoma? Take your drops. Don't fall out of the system. Keep doing those studies. They're annoying to do. They're no fun, but if you stay in the system, most people do not go blind from glaucoma. I tell people that the whole purpose of glaucoma management is so when we all go up and we see the pearly gates, that we actually see the pearly gates. So glaucoma is not going to go away. You're going to have it for the rest of your life. The point is when your natural life is done, you can still see at the end of it. And that is the purpose of glaucoma management. So stay in the system. Usually there's a lot you can do if you stay in the system. If you come in at the end of the disease, it's a lot harder to manage than if you come in at the beginning of the disease. Okay, macular degeneration next. Wow, I didn't think this talk was going to last an hour, and apparently I'm only 2/3 of the way through. Any quick questions from glaucoma? Take a quick break and then we'll do macular degeneration. Yes?
You said earlier that a doctor has to evaluate you for glaucoma.
Yes.
Does that mean an ophthalmologist?
Yes, or an optometrist.
Or optometrist doctors?
Optometrists are doctors of optometry. Ophthalmologists are medical doctors. I went to medical school, similar to any other doctor that you think of. It's a different level of training. The optometrists, they specialized in a 4-year school just on evaluation of eyes and eye disease, not the how does the whole body work and how does it manifest in the eyes, and then a 4-year residency on how to treat it, what does it look like, all the subspecialties, but additionally all of the surgeries. So being able to evaluate and diagnose, I have every confidence in every one of the optometrists here in Fairbanks to be able to look at that and say, I'm worried about you having glaucoma. And if you have any questions, I mean, my optometrist is phenomenal. I'm overwhelmed by him on a regular basis. So, yes?
In regular eye exam, if they don't do the little puff and don't do the little tap, what does it look like to get a glaucoma test? You said there's other tests.
Well, doing screening tests. There's something to be said for screening tests. And, tonopens for screening tests, I don't do them I do them in my post-op patients. I don't do tonopens because because, you know, I'm going to try not to answer this in a super politically correct way. You probably should be acclimated.
What's that?
You probably, if you want an evaluation for glaucoma, you need to be acclimated. You need to have somebody do an applanation tonometry. And you know, like I said, the pressure, once you have the diagnosis of glaucoma, there's absolutely no excuse to not do applanation. So, because, I mean, if you're going to change therapy based on someone's 17 or 20, and that's within the margin of error for a tonopen, that's not acceptable. So, you know, the gold standard is applanation tonometry, gold line applanation tonometry. So, it is part of my regular exam. So I don't know, I can't tell you what it happens elsewhere, but it is part of my regular exam. Unless you're a post-op. The only time I use tonopen is on post-ops. Because you don't want to touch the eye that much on them.
And they just, what is it like? I mean, what is...
Oh, your eye's numb. No, your eyes, or the gonioscopy you touch, and every new patient of mine gets a gonioscopy, period. Because everyone should have a gonioscopy at least once. So, you know, you just touch, your eye's numb. I mean, it takes 15 seconds. I mean, it's just like that. You wouldn't even think about it when you do it. So in the applanation tonometry, when they check the pressures, again, your eye's numb, and you know, it comes in. You don't really feel it touching you. You just have to stare at someone's ear for 20 seconds, and they check it. And so it's super fast. It's painless, not an issue. You wouldn't even know what's happening.
And then, for her benefit, to numb the eye, it's just a drop.
Just a drop. Yep, just a drop to numb the eye. And when you do the applanation, you put a yellow drop in. So, because it actually, you put a fluorescent blue light on it, and it fluoresces and it fluoresces in a certain way. You use that to be able to check the pressures. That's very, very easy.
Well, clearly you said if you have cataract surgery, then you won't get glaucoma, is that true?
No, it's not true at all. Although cataract surgery can lower the pressures for sure, they're two entirely different diseases. You won't get pupillary block acute angle closure glaucoma once you've had cataract surgery. That subset of cataract or glaucoma you won't get after cataract surgery. But that's pupillary block acute angle closure. That's that catastrophic event, you know, pressures of 80 in the ER. That one you won't get once you've had cataract surgery. That is true. But that's the only kind of glaucoma you don't get anymore. Yes?
You mentioned frequent checks. My optometrist is encouraging me to 6-month checks. What's your idea of frequent?
Part of it depends on the severity of glaucoma. So I tend to, my advanced glaucoma patients are the patients that I'm very concerned about, I'll see every 3 months. The patients that are kind of intermediate, I'll see every 4 months. The patients that are mild, I'll see every 6 months. Every once in a blue moon, and honestly, I don't think I've been in practice long enough to quite get comfortable saying it's a year. But if I had somebody who 10, 15 years, usually honestly by that point in time they're seeing my optometrist because they have very, very mild disease, maybe annual. But again, I'd probably see it, if you have glaucoma, I'd probably check at least 6 months. But again, it's based on the stage and and your pressures and your stability. So, if that's an answer. Not knowing what the stage is.
Well, he
But-
doesn't talk much, so.
But it's got to be a good sign if you want to see you in 6 months instead. It's not a bad sign, certainly. Shall we take a quick break and then do macular degeneration? Just keep going? Okay, if people want to walk out on me, I do not take it personally. Okay, what is macular degeneration? Macular degeneration is an age-related process in which you have a degeneration of this regulatory layer underneath the retina. So that is the layer that goes bad in macular degeneration. It's called the RPE, the retinal pigmented epithelium. What is the macula? So why is the macula important? The macula is the center of your vision. This is the macula right there. This is, if you hold your hands up like this, right there, that is your macula. That is the center part of your vision. That is where the light is focused most directly, most specifically on that teeny tiny little spot right there, called the fovea. The fovea is where you see the finest, most perfect detail. That's your 20/20/2015 vision is your fovea, right in the dead center of your macula. So who's at risk for developing macular degeneration? Anybody getting older, unfortunately. So over the age of 50, the risk increases with age. The incidence of macular degeneration is going up dramatically because we are all living longer. Life expectancy is much higher. People who were used to die in their 50s, they never got macular degeneration. We're now living into our 70s, 80s, and 90s. Well, a lot of people get macular degeneration when they're 90. Family history of macular degeneration definitely goes along with it. Ethnic, there's Caucasians, unfortunately, are much more likely than African Americans, for example. So up here in Fairbanks, we are predominantly Caucasian population. Lot of macular degeneration. Lot of macular degeneration. Smoking, significant increased risk. Significant increased risk. 2 times risk for smoking. How is macular degeneration detected? So basically, an eye exam with your doctor. So have your doctor evaluate, take a look at the macula and see what it looks like. The visual acuity, unfortunately, is often not a very good indicator for any significant disease, at least in the earlier mild or moderate stages. Very good vision maintained through even intermediate stages of dry macular degeneration. You need to have a dilated exam. We'll talk a little bit more about Amsler grids and OCTs, and then fluorescein angiographies. That's where you inject a vegetable dye and you can actually watch it circulate through and see the pattern of disease. We don't really do that as much anymore since the onset of the OCTs, and the new injectable treatments for it have basically taken that a bit out of macular degeneration evaluations, which is good because there's a lot to it. What's dry macular degeneration? Is that the right? Yeah. So dry macular degeneration is the most common form. 90% of people who have macular degeneration have dry, stay dry. So everyone who has macular degeneration out there, whether you have wet or dry, you have dry. So dry is kind of the baseline. 90% of people stay dry. 10% will turn wet, but 90% stay dry. Most people will actually say that for the rest of their life and they'll never have a problem. Many people out there have no idea they have macular degeneration because early stages are often asymptomatic. So essentially the pigment layer below the retina that we talked about, that RPE, it will actually form irregularities, it will mottle, you'll get pigmentary changes, you'll get these drusen in here, and those lights, the light sensitive, the photoreceptors, the part that actually take that light and make it into the chemical change that goes into the electric nerves, that actually starts to break down. The photoreceptors are actually lost because that regulatory layer protects those photoreceptors. So when the regulatory layer goes bad, those photoreceptors go bad. What are drusen? So in addition to being a sign of macular degeneration, they're basically deposits of lipid and proteins between the pigment layer and the retina. And whether their exact role is not actually 100% understood. Are they causative? Are they effect? Do they play a role? Are they just a warning sign? They come and they go, they change and they move. They are associated with more advanced stages. Drusen such as this would actually be a high-risk characteristic. The bigger they are, the more confluent they are, the worse it is. So again, normal and drusen. So you can see the drusen right here along that. This is normal, and then you can see them deposited between normal and this is the other layer right above that's actually your photoreceptors. That line right there above the small orange line, that's the photoreceptors. So you can actually see those drusen placed between the RPE and the photoreceptors. So 3 stages of dry macular degeneration. So early, most people have no idea. You have a few drusen, a bit pigmentary modeling. Early stages, asymptomatic. Your doctor sees and says, hey, by the way, you have macular degeneration. You say, whoa. Most people are going to stay and do perfectly fine with this. Remember that. Intermediate, again, more modeling. You might notice that there are some wavy lines out there. You might look at some grids and say, oh yeah, it is a little bit asymmetric. Or yeah, I can see if there's a little bit of a wave in there. You start having slightly increased risks for developing further problems from this. Advanced macular degeneration is where you have something called geographic atrophy. So those photoreceptors have been, that pigment layer went bad enough that the photoreceptors couldn't survive, and so they actually died. And so you actually have big areas of just atrophy or wasting away of the retina itself. And that unfortunately causes a fairly significant amount of vision loss, ranging from mild to moderate to really unfortunately quite advanced vision loss. Sometimes quite advanced vision loss. So this would be an example of what it looks like to have advanced macular degeneration vision loss. The center part of your vision is very obscured and you're living on the periphery. Now you still have the peripheral part of your vision, which is fantastic. Glaucoma, when it goes bad, end-stage glaucoma, when you're blind from glaucoma, you're all black blind. I mean, all black blind. Macular degeneration, you're not all black blind. You can still see around the edges. What's wet macular degeneration? So wet macular degeneration is where that regulatory layer goes bad such that the plexus of blood vessels underneath the retina can actually grow up through that membrane, grow up into the retina, leak and bleed. That bleeding, if left untreated, will cause scarring, fibrosis, and that scarring and fibrosis is irreversible. Once it gets to that fibrosis stage, there's nothing you can do for it. It's brain tissue. Brain tissue that's scarred is damaged. It cannot be undamaged. So, symptoms of wet macular degeneration. Anyone who has macular degeneration should be using an Amsler grid. So an Amsler grid, and I'll show you that in a minute, is this little grid. Do I have it there? Yes. So this is an Amsler grid. An Amsler grid has these lines. You can see that the grid becomes distorted. Parts are wavy, parts are black or missing, zigzags, things just become extremely blurry. Any changes in that grid, you need to be seen within 12 to 24 hours. If for any reason any of you have macular degeneration, you can't get into your regular doctor, your doctor's out of town, or whatever the case is, call my answering service. If you have macular degeneration and you have new onset Amsler grid changes, that is a significant concern for the progression of either dry to wet or reactivation of a wet. We have a window in which we can treat this and actually have fantastic outcomes. But you need to stay in that window, and the window is not, oh yeah, about a month ago things were really wavy and now I can't see. Nothing I can do at that point in time. Hey, yesterday I used my Amsler grid and it's really blurry. I thought I'd wait until 8 instead of calling you at midnight. Perfectly fine. Perfectly fine. So, but you should call me that day, next day. So, how do you treat it? Dry macular degeneration, essentially you observe. So, use your Amsler grid and use it every day. Cover one eye, use it, cover the other eye, use it, and make sure you're using it every day because the earliest warning sign is when you notice something. You can get in. So, AREDS 2. There was a vitamin supplementation, and there was a big study that looked at vitamins for macular degeneration and found that they actually will slow the progression of macular degeneration from people who have high-risk dry, had a less likely to progress to wet taking the vitamins than not taking the vitamins. We also have a new study out more recently called the AREDS 2 study, which took out one of the medications that was known to put you at increased risk for lung cancer, got rid of it, and put in lutein. So lutein has additionally been shown to improve visual acuity in all patients with macular degeneration, as well as being preventative for the progression from dry to wet. So the AREDS 2 supplement, when that came out almost a year ago now, I switched everybody in my clinic. So now it's easy. There used to be do you have a smoker formula or a non-smoker formula? Now it's everybody takes AREDS 2. And if you look what the AREDS 2 formula is, it's out there. Companies have it. It's marketable. If you have any questions, people have a hard time finding it. So I called Bausch & Lomb and I said, send me a couple cartons and I'll have it for people who need it. And then thank goodness Fred Meyer started carrying it. So, but if you have any questions, you can always stop by my office to make sure that you're taking the one that is recommended. The AREDS 2 now has made it very easy. Everybody should be taking AREDS 2. That means you also need to adjust your vitamin schedule. So if you take very high dose vitamin C, then please adjust it such that you don't take too much. You want to make sure that this is very high dose as it is right now. So also, don't smoke. Smoking is the worst thing you can do for macular degeneration. It is like kerosene to a fire. So quit smoking. Don't start smoking if you have. Eat a healthy diet, lots of vegetables. Omega-3 fatty acids didn't actually show an improvement in the macular degeneration. That was part of the study for the AREDS 2, and there was no improvement in macular degeneration with omega-3s, but good for your heart. But lots of green leafy vegetables. So wet, if there's any evidence of wet macular degeneration has become a very treatable disease in the past 6 or 7 years with the advent of the new intravitreal injections. These injections actually neutralize the chemical, and I'll show you a little cartoon in a minute. It actually neutralizes the chemical that causes this new blood vessel growth from happening. So unfortunately, they often need to be repeated. They actually literally are sticking a needle into your eye. For those of you who've had it or seen it, they're not as bad as it sounds. I know that whole, cross my heart, hope to die, stick a needle in my eye. I know it sounds terrible, and everyone's like, you're sticking a needle in my eye? What? No, it's actually, believe it or not that bad. On the grand scheme of things that people have, you're not going to volunteer for it just for kicks, but if you have to go through it to be able to see, fantastic. So the injections in the eyes are not that bad, and they work. They really, really work. In fact, overnight, they basically made this other thing called photodynamic therapy useless. I've never even done one because Avastin came out in my second year of residency, and all of a sudden, everybody did Avastin. Everybody did Lucentis. It works way, way, way better than the photodynamic therapy or any of the prior. This is not working very well, is it? Any of the prior treatments. So, is treatment effective? Absolutely. This is what the difference is. You take someone with that, a few injections later, they look, this obviously, this is the fluid. This is all fluid in the retina. This is what macular degeneration does. Tons of fluid, you can't see, everything's wavy. This will cause scarring if left untreated. And with treatment, you go back to that. Now, this is macular degeneration right here. I mean, this is all of those drusen, those irregularities. That's what it looks like. That's dry. This is wet. And the injections actually work. They work fantastically. So how does it work? So this regulatory layer down here releases this thing called VEGF, vascular endothelial growth factor. So the little VEGF particles are actually released by that pigment layer. And those actually cause the new blood vessels to grow. And it basically is a, hey, I need more blood, so come give me blood vessels. And so the blood vessels grow, but they don't grow healthy, and they leak, and they bleed, and they tear, and they do all these terrible things. So you inject something called an anti-VEGF, Avastin, Lucentis, Eylea, and it comes in and it neutralizes those VEGF particles and makes them go away. Takes them away, they're gone. Unfortunately, of course, the RPE is still the issue, and so those VEGF chemicals are still made because the disease process is actually in that pigment layer, not the particles themselves. So this is an intermediary for the disease, but inject again, you can keep neutralizing it. So the medications last about a month-ish until you have to repeat it every month. So, which is annoying, I realize that. However, the treatment works. So you can take someone who comes in 2200 and they can walk out 2 months later, 3 months later, 5 months later, 2030. I mean, it's amazing. It actually fantastically works. But you need to catch it early enough. So you need to use that Amsler grid. You need to be able to catch it before the scar forms, because once the scar forms, there's nothing I can do about it. And unfortunately, sometimes that scar does form, and sometimes the geographic atrophy does go, because there's nothing I can do for geographic atrophy. And sometimes you do get into a situation where you have very, very poor vision. And sometimes, even despite the curve of vision loss for macular degeneration, grab a folder. The curve of vision loss used to be like that, just a downward slope. Because of the new anti-VEGF therapies, it's come up about like that. So the slope is still down, but it's at a much, much more shallow angle. So there's a lot of hope out there for wet macular degeneration. However, unfortunately, some people do end up still with fairly severe vision loss. And so low vision clinics, there's a lot that can be done. I actually just started a low vision clinic last year. We didn't really have very much in the interior available for us, so I now am funding the education for an occupational therapist, and she is becoming the interior's only low vision specialist occupational therapist. And we have a lot of resources available excuse me, through my foundation, Mountain View Foundation, which is admittedly just in the process of forming, but we are doing a matching grant. So for every dollar spent on low vision aids, we'll match $1 for it, so it halves the price of it. There's a lot available for macular degeneration and for low vision people in general, not just for macular degeneration. So there's a lot out there. And there's more that's coming. But certainly with the new low vision clinic out there, there's hope, and there's a lot of education that people can have for low vision stuff. So, and more coming. And that's it.
Drusen lines, the present there. Wouldn't the statins help control that if you had macular degeneration? Do statins help any?
No, unfortunately they don't. It's not like it's a cholesterol kind of deposit. It's just, it's basically, it's like byproducts, essentially. of the breakdown that are deposited. Yes?
So the ARED2, is that only when people have been diagnosed with macular degeneration?
Yes.
It's not
It
preventative.
is not preventative. There is nothing, unfortunately, preventing a healthy diet, good living, don't smoke. Unfortunately, your genetics are what your genetics are. But no, there's nothing we have to prevent macular degeneration forming. In fact, I would not recommend the AREDS2 because there is some issue with the high dose vitamins. Anytime you take anything in high dose, there are side effects associated with that. The benefits far outweigh the risks if you actually have the disease.
What about
That's with any form. AREDS2, if you have macular degeneration, remember, everybody has dry. You have wet on top of dry, but everybody has, if you have macular degeneration, you have dry. All you can do with the treatment of wet is get it back to dry. So if you have wet, treating that gets you back to dry, but the progression of dry is very slow.
And for people who don't have it, what about the multivitamin with lutein? Is that
I'm not gonna. Yeah, there's a big debate about the value of multivitamins. Lutein, it's probably. It's not really going to help you prevent the formation of macular degeneration. Lutein has been shown to improve things once you have it. There's actual debate in the literature right now about the relative value of multivitamins in general. So I think that eating, and incidentally, the AREDS2 study showed that people who eat a very healthy diet full of green leafy vegetables and all the things that we're supposed to do, the AREDS2 had actually not an enormous effect on them. It's for people who have the typical American diet, which does not include kale and broccoli and spinach. But if you eat a very healthy diet, you actually are doing fantastic things for your body, both probably for the prevention, although I can't attest to that, no study's been done, but certainly with the AREDS2 study suggesting that if you eat that kind of stuff naturally, that the supplements actually don't really do very much for you because you're already getting it.
If you take the AREDS2, and you also take a multivitamin, is that kind of going over the top? Or?
Multivitamins usually have a whole bunch of other things in the AREDS2. The AREDS2 can be taken with a multivitamin.
And can you only purchase them through your clinic?
Oh no, they're available in the grocery store. Yeah, they weren't for a while, and sometimes they sell out. And so I had the 10th patient who said, "You told me to take this, and I can't find it anywhere. I've gone to 7 stores." And so finally, I just bought some. And I mean, I make no money on it. I think I actually probably lose about $1 on them. But I want to make them available. I'm telling people you need to take this, and then they can't find it. So.
And you can buy them without a prescription? Or
Yeah, they're over the counter. Yeah, they're usually in the vitamin aisle. Yes.
I had iritis for a time a number of years ago and took steroids for that. Is there anything I should especially watch out for?
No, the likelihood of cataract formation is high, but if probably just for an iritis, it wasn't for extremely prolonged, probably just for a week or 2, maybe even 3 weeks. Oh, long time?
Maybe a month at a time for maybe 10 or 20 different episodes.
Yeah, you probably have some cataracts formed. So, you can come see me, we can take a look at it. Like I said, cataracts, I'm not afraid of cataracts. Cataracts are nothing to be afraid of. You take them out, in, out, done, bam, no problems. The other stuff I'm talking about now, those ones don't go away. Cataracts are, I'm not afraid of cataracts. So, but come see me about that one, and hopefully someone's worked up the iritis because that needs to be worked up.
Is there a location for this low vision clinic? You didn't capitalize it.
No, it is through my office. So, yep, it's literally, I think January is when it started. Or maybe December, but it's very new, and I'm just trying to get the word out there right now about it. So, but yeah, there's a lot people can do, a lot.
If you have a cataract developed due to a vitrectomy on one eye, and you replace the lens, how do you deal with the fact that the vision is so different in each eye?
That's an excellent question. That's called anisometropia, and that in and of itself is an indication for cataract surgery in the other eye if needed. So oftentimes it's difficult for the brain to fuse if the prescriptions are too far off. And that's a huge issue. It's actually, the issue is mostly that nearsighted lenses minimize and farsighted lenses maximize. So the image, the size of the image, you can't, the brain can't quite fuse those two. It's like trying to fuse a quarter and a nickel. I mean, they just don't go because one's bigger and one's smaller. And the brain, I mean, that's a really big issue. And that the main ways are either a contact lens or cataract surgery. And there's not an enormous amount to do about it.